And now with this voiceover, we're going to go ahead and talk about acute coronary syndrome. And what acute coronary syndrome is a term that we use for different kinds of conditions that we're going to talk about with this voiceover. Primarily, we're going to be talking about unstable angina, myocardial infarction, and sudden cardiac death are all categories that fall under acute coronary syndrome. And it's basically just any condition that can be brought on suddenly. It's reduced blood flow to the heart, and any condition that can also cause chest pain that someone can feel during a heart attack or any kind of pressure in the chest with at rest or doing light activity, which would be considered your unstable angina, and the heart all of a sudden stopping or going into a lethal arrhythmia, which can be sudden cardiac death. So we're going to go ahead and start. When we're talking about separating it, and we can look that we can have the acute coronary syndrome. Here we have unstable angina. We can either have a non-ST elevation MI as well, and we can have an ST elevation MI, which can fall under the coronary syndrome category. This is usually the etiology and pathophysiology of the disease. We have the plaque that is formed. That plaque will rupture, causing some form of platelet aggregation, and a thrombus is formed. It can cause either partial occlusion, which the patient or the client will feel unstable angina, or at the same time can have non-ST elevation MI, or you can have total occlusion of the coronary artery, which at that point would be considered ST elevation MI. And the way we treat both of these patients is completely different, which is important to know what are the different categories and why we treat these patients differently. And there's certain reasons why we do that. And once this stable ruptures, which is your step 2, what ends up happening, a lot of platelets go into the area, which is their job, because they feel that there is an injury. There is local constriction that occurs, which is some of the vasoconstriction occurs due through inflammation, and that thrombus forms. This unstable lesion, depending on how big the occlusion is, may be partial or totally occluded, and sometimes this coronary plaque suddenly becomes unstable. We don't fully understand what can cause it to become unstable, but we know that part of our body's response to that is inflammation, and they believe that inflammation could also be part of the reason why this plaque becomes unstable. Patients that have acute coronary syndrome do require immediate hospitalization because their symptoms need to be managed in a hospital setting. So when we consider an unstable angina patient, it can either be new onset for them, and if their plaque obstruction is bad enough, that can be their first sign of chest pain, and they need to be hospitalized because they will either go into an MI. And when we're talking about unstable angina, it's any time that this chest pain will continue even at rest, because most people, when they do have what we consider stable angina, is someone that can take nitro and they will rest and the pain goes away. But when it's unstable, it occurs even at rest, and sometimes it's getting worse and worse. The patient with stable angina, like I said, will sometimes get this chest pain. They take those nitros and they seem to be okay. The If the patient gets a this chest pain during sleep or even at rest, we need to educate our patients that once they start taking their nitro, and if after they take the 3, the pain is still there or it continues to increase, they need to go ahead and call for help. They call the 911, they or they need to go to the emergency room immediately. And unlike chronic, unstable angina is predictable and is considered an emergency. If a woman gets the symptoms of, or she gets MI symptoms, as their symptoms are not as common as the traditional symptoms of the chest pain. With women, sometimes they'll just get shortness of breath, might get some indigestion, they'll feel anxiety. But fatigue seems to be the most prominent symptom. And we know that fatigue is very common, so a lot of times they'll have this and they don't come into the hospital because they'll just think that these symptoms are coming from something else. This diagram is just showing the different kind of narrowing that we can have. Once there's narrowing in the coronary artery, due to the insufficient blood flow that goes into the myocardial tissue, chest pain will occur secondary to ischemia. And if you look on the other side with coronary syndrome, when we're looking at EKG changes, if we see an ST elevation, then it's going to be STEMI. On the other side, if we have cardiac markers, if they're not raised, then it would be unstable angina. But the moment that they do become raised, but there's no EKG changes, then that's non-STEMI. So MI will occur because the individual will have ischemia that is not going away. This ischemia eventually leads to myocardial cell death and necrosis. This can happen sometimes even in anything greater than 20 minutes. 80 to 90% of all MIs occur because the thrombus develops and the blood to the myocardial tissue is blocked. And at that moment, that surrounding tissue is going to become necrotic. The process of MI, when it's an acute MI, it takes time. Cardiac cells can withstand a little bit of ischemia, but anything greater than 20 minutes, at that point, cellular death occurs. The earliest tissue to become ischemic is usually the subdencardium. This is the innermost layer of the cardiac muscle. If this ischemia continues, it takes approximately 4 to 6 hours for the entire thickness of the heart muscle to become necrosed. If the thrombus completely occludes the artery, the time for complete necrosis may be as long as 12 hours, and that's if the thrombus is not completely blocking the artery. Contractile dysfunction stops in necrotic areas, so that means those myocardial cells do not fire. The degree of altered function depends on the area involved and the size. As we know, certain areas of the heart have more coronary arteries than others. So with this diagram, we can see the different locations and how much ischemia can form based on the location of blockage. And sometimes we can locate these areas of damage by different sections. So we can say anterior, inferior, lateral, septal, and posterior wall infarction. So we have different types. Usually it's the left ventricle that's involved, and if you can see on the left side we have bigger, longer descending coronary arteries compared to your right side. And the location of the infarction correlates with the involved coronary circulation. So, for example, if the right coronary artery provides blood supply to the inferior wall, blockage to the right coronary artery will result as an inferior wall MI. So it's based on location. Anterior wall infarctions result from blockages in the left artery, descending artery. If you look at the picture, you can see that. Blockages in the left circumflex artery usually cause lateral or posterior wall MIs. Damage can occur in more than one location, and that's if they do, that's usually a pretty bad MI, especially when they have more than one coronary artery involved. The degree of pre-existing collateral circulation makes such a big difference on the severity of the infarction. Remember, with collateral circulation, the individual can still have perfusion to part of the heart. Someone that has a long history of CAD will develop, and as we saw that, they will make collateral circulation on their own. This is one reason why a younger person may have a more serious first MI than an older person. That's because the older person has had time to develop these collateral circulations, which continues to provide oxygen-rich blood to the myocardial tissue, versus someone who is young and develops symptoms because they don't have this collateral circulation. Their outcome is worse. This diagram here is just showing you the area. You can see in the picture that black part of the myocardial muscle, and it's completely black, and it's fully ischemic. Now, depending on where your zone of injury is, you can see the different EKG changes based on, if we're looking at the picture to the left, if you see the damage there in that different zone, you have a different kind of ST elevation there. And then you have the reciprocal changes on the other side. Reciprocal changes just means opposite. Same thing with your other picture. You can take a look at the different kinds of injury patterns that we can see in a 12-lead EKG. So pain is the first thing that brings our patient into the hospital. They're going to experience the severe chest pain that's not relieved with rest. It's not relieved with nitro, and that's usually a hallmark that we're dealing with an MI. This pain will remain persistent. Patients come in complaining of heaviness, pressure, burning, constriction, crushing. Some of the common locations are the substernal, retrosternal, epigastric areas, and sometimes people may feel that they're having indigestion and take antacids, but these antacids, of course, are not going to provide relief because it's not GI symptoms that they're dealing with, but they're dealing with ischemia. Sometimes this pain does radiate to the neck, lower jaw, arms, to the back. It occurs while the person is active or at rest, asleep, or awake. Usually occurs in the early morning hours. It can last up to 20 minutes or longer. More severe than angina pain. And as we've mentioned before, not everybody has classic symptoms. Some people may not experience pain but may have just a discomfort, weakness, or shortness of breath. Although men and women have similarities in their symptoms of an acute MI, there's also differences. With some women, they'll have atypical discomfort to shortness of breath and fatigue, as mentioned in previous slides. If the patient is older or an elderly patient, they may just experience mental changes, confusion, shortness of breath, dizziness, may even have a dysrhythmia. Patients that are diabetic may have a silent or asymptomatic MI secondary to cardiac neuropathy. They may have shortness of breath. As we mentioned, description will be some heaviness, tightness, burning. It usually lasts about 20 minutes or more, and most clients or patients know the difference because this pain will last more than 20 minutes. What ends up happening is that during the initial phase of this MI, this ischemic myocardial cells will release catecholamines, and catecholamines is your neurepi and epi, which is your fight or flight enzymes that are normally found in our cells. So this is released. So initially, the patient will have tachycardia. They'll come in diaphoretic. They have the vasoconstriction, and they're clammy, cool to touch. So when this neurepi and epi are released, it also results in the release of glycogen. And that's why, due to the glycogen, is how people become diaphoretic and vasoconstriction. On physical exam, the skin will be very ashy and clammy. And due to the release of the catecholamines, initially BP and heart rate will be increased, but later it's going to drop because our body's going to experience some decreased cardiac output. And if severe enough, this can affect our kidneys, which will, because when the cardiac output drops, there's not going to be enough perfusion available, so our kidneys are not going to get that renal perfusion, and urine output's going to drop. Sometimes crackles may be present, and if present, may persist for several hours to several days. If that is present, that's usually a suggestion that someone may be having left ventricular dysfunction. JVD may be present, hepatic engorgement, peripheral edema, and if this is indicated, that might mean they have right ventricular dysfunction. So can you see the differences between right and left? A cardiac exam is going to show abnormal heart sounds. Sometimes they're distant. May hear S3, S4, and these S3s and S4s is usually a suggestion of ventricular dysfunction. There may be a loud or holicystic murmur that may develop, and this may indicate septal defect. May also indicate papillary muscle rupture or any kind of valve dysfunction. Nausea and vomiting may be present for some of these patients, and these usually occur from a result from reflex stimulation of the vomiting center due to the severe pain. I may have a vasovagal reflex that is initiated from the area of the infarcted myocardium. May have an increase in temperature, usually within the first 24 hours. Can be as high as 100.4, and the elevation may last as long as 1 week. And that's usually due because there's that systemic inflammatory process that is caused due to the myocardial cell death. This little diagram is just giving you an overview of some of the symptoms they're going to come in with, and some of the findings and part of our treatment as well. Now, as far as when healing process begins, the body's response to cell death is inflammatory process. We know that that's going to happen within 24 hours. There's going to be a huge infiltration of leukocytes around the cell death area. Proteolytic enzymes of the neutrophils and macrophages begin to remove this necrotic tissue by the 4th day. And at this time, the muscle wall is very thin and fragile. The necrotic zone is identified by an EKG or ECG changes. We'll see a ST segment elevation, pathologic Q wave, and binuclear scanning after the onset of symptoms is how we would see these ECG changes. At this point, the neutrophils and monocytes have cleared all of this debris. So they came in, took out the garbage from the injured area, and the collagen matrix will be laid down. That's just they're going to form scar tissue around the area. After 10 to 14 days, the scar tissue is still really weak. So this myocardial continues to remain vulnerable to increased stress during this time because of uh, the unstable state of the healing heart wall is that this myocardial tissue is still weak. It is also at this time that the patient's activity level may be increasing, so special caution and assessments are necessary. By 6 weeks after MI, scar tissue has been replaced by necrotic tissue, and the injured area is considered healed. By 6 weeks after an MI, the scarred area is less compliant than the surrounding area because if we know that scar tissue is thicker, this condition may be manifested by uncoordinated wall motion in the heart, ventricular dysfunction. Sometimes there'll be altered conduction patterns or some heart failure as well. These changes in the infarctic muscle can also cause changes in the unaffected myocardium as well. In an attempt to compensate for the damaged muscle, the normal myocardium will hypertrophy because it's working more trying to compensate for that scarred area. And this process is called ventricular remodeling. And remodeling of normal myocardium can lead to the development of late heart failure, especially in the individual with atherosclerosis of other coronary arteries and or in arterial MI. Complications of MI. Many times we'll see dysrhythmias. These are pretty common, and it's usually present in about 80 to 90% of our patients. Some of these dysrhythmias can cause death in our patients. Sometimes we'll see these while our patient is hospitalized. Any condition that affects myocardial cells, sensitivity to nerve impulses, we'll see electrolyte imbalances, central nervous system stimulation. All of this can cause dysrhythmias. The intrinsic rhythm of the heart is disrupted. Sometimes we'll see tachycardias, bradycardias, or we'll see irregular heart rates, all which adversely affects the ischemic myocardium. Some of the life-threatening dysrhythmias that we see may occur often with anterior wall infarct, heart failure, or shock. A complete heart block develops when key portions of the conduction system are destroyed because they cannot participate in conduction. Ventricular fibrillation is a common cause of sudden cardiac death, and as we're going to learn later, that any kind of ventricular dysrhythmia is lethal. If this does occur, it usually occurs within the first 4 hours after the onset of pain. PVCs may be present as well, and these may precede ventricular tachycardia and fibrillation. Life-threatening ventricular dysrhythmias must be treated immediately. Another complication that can occur with MI is heart failure and cardiogenic shock. And usually with heart failure, it's just a complication that occurs when the pumping action of the heart is reduced. And it depends on the severity and the extent of the injury with the MI, whether heart failure will occur or not. The initial symptoms are just like some mild dyspnea, restlessness. Patient gets agitated, look up in the monitor, patient's tachycardic. Other symptoms, very common here in S3 or S4. X-ray gets done and there's a lot of congestion there, and heart sounds on auscultation. Like I said, you'll hear the S3, S4, and so you'll have some crackles as well. JVD will be present. Another complication is cardiogenic shock, which is a pretty bad complication because the heart itself is going into shock, and it's when the heart cannot pump enough blood to meet the oxygen demands of the body. So that when the patient does go into cardiogenic shock, it is an increased mortality rate. The goal is to maximize oxygen delivery and reduce oxygen demand. This prevents complications of the kidneys. As mentioned before, if there's not enough perfusion, our kidneys will be affected. Patient will come in, they'll have signs and symptoms of clammy skin, weak pulse, pale. They'll be pale, cold hands and feet. They'll have shortness of breath and increased respiratory rate. As I said, it occurs when oxygen nutrients are supplied to the tissues inadequate because of severe left ventricular failure. This occurs less often with the early and rapid treatment of MI with PCI or thrombolytic therapy. That's why time is important. So if they get in, they get treatment, it's less likely to occur. When cardiogenic shock does occur, as mentioned before, it has a high mortality rate. If it gets to the point where it gets really bad, they may need an aortic balloon pump and any kind of support to support contractility. A lot of times vasoactive drugs are used, and hopefully the patient recovers from this cardiogenic shock, and then they're able to move forward. Another complication that we will see too is when the papillary muscle dysfunction occurs. That's usually around the infarcted area or near the papillary muscle. It attaches to the mitral valve. This is rare and not common, but it is a life-threatening complication because what happens is it causes massive mitral valve regurg. There's dyspnea, pulmonary edema. There's a decrease in cardiac output, and that's from the backup of the blood in the left atrium. This condition will make the already damaged left ventricle worse, further reducing cardiac output, and there's a rapid deterioration on the patient. If this does occur, the treatment is going to be rapid afterload reduction with nitroprusside, nipride, and aortic balloon pump therapy, and immediate cardiac surgery with mitral valve repair or replacement. Ventricular aneurysm, this results when the infarcted MI wall is thin and bulges out. When we talked about the aneurysm lecture, we could tell that aneurysm is just like a bulging out. So this can happen too in the ventricular area. This can develop within days or weeks or months. The patient with ventricular aneurysm may experience heart failure as well, may have some dysrhythmias and angina. Besides ventricular rupture, which is fatal, ventricular aneurysms harbor thrombi. These can lead to an embolic stroke as well. Another complication that the MI patient will experience is pericarditis. And itis is inflammation, so there'll be inflammation of the visceral parietal areas of the pericardium. This results in cardiac tamponade and decreased ventricular filling and emptying and heart failure. This will usually occur 2 to 3 days after MI as a common complication of the infarct. Chest pain may vary from mild to severe. It's aggravated by inspiration, coughing, movement of the upper body. Sitting in a forward position often relieves pain, which is like one of those cardinal signs. Assess the pain with suspected pericarditis for the presence of a friction rub over the pericardium. Fever will be present because it is an inflammation. Patient may have hypotension, narrow pulse pressure, and all of this is associated with decreased left ventricular filling and emptying. Diagnosis of this can be made with a 12-lead EKG. Sometimes EKG changes that would be noticed is diffuse ST segment elevations. This reflect the inflammation of the pericardium. Treatment includes pain relief with NSAIDs, aspirin, and corticosteroids. With Dettler syndrome, all this is pericarditis, but with effusion, and also this one can develop 4 to 6 weeks after MI. And what they believe happens is this antigen antibody reaction to the necrotic myocardium. Patients will come in with complaining of pain, fever. We'll hear a friction rub, pericardial effusion, and arthralgia. For the laboratory findings include elevated white blood cell count, sedimentation rate, and the treatment is short-term corticosteroid therapy. With this unstable angina and MI, some of the diagnostic tests we do, very typical for the patient to come in, start complaining of chest pain. The very first thing we do is put them on a monitor, and then we'll go ahead and do a 12-lead EKG. And of course, at one point we draw labs as well, but the 12-lead EKG is one of the ones that will let us know immediately. It's a very easy test to do. We can do it right at the bedside. We only um, takes less than a minute to get a result once we connect the patient. The thing with the 12-lead EKG, you got to make sure you tell the patient to uh, remain still and calm as best as possible because you want to get a good reading on this. You don't want to miss anything. What the 12-lead will show is usually they'll have changes in the QRS, ST, and T wave. So some of the changes that you'll see with the QRS and ST and all this is with ST you'll either see depression or elevation. Same with the T wave, and QRS maybe you'll see like a Q wave right before it. And for diagnostic and treatment purposes, it's important. We have to remember I said that we do different treatment options, whether it's an ST elevation MI, if it's just unstable angina or STEMI. All of this will let us know what we need to do. Everything is time, so time is tissue, so we need to make sure that we find the right treatment intervention for our patient. Patients with STEMI tend to have more extensive MI because if you recall in the beginning of the lecture, patients with STEMI have they can have a full occlusion, anywhere else, a complete coronary occlusion, and when they do have this, what we'll see is what we call a pathological Q wave on the ECG. Patients with unstable angina or STEMI usually will have some transient thrombosis or incomplete coronary occlusion and usually do not develop these pathological Q waves. Because the MI is a process that involves time, and I said the quicker we know, the faster we can act and give the patient the right treatment intervention. The EKG must be read very carefully, and we have to look at all the different leads to see where the injury is. It may also be normal or non-diagnostic when a patient comes to the ED with complaints of chest pain. The ECG may reflect the infarction process. That's why it's important to initially do a 12-lead ECG. And like I said, they're pretty easy to do. With the serum cardiac markers, it's one of those really important tests that we do. So when a patient comes in, like I said, we're going to put them on a cardiac monitor, we're going to do the 12-lead EKG, and at the same time we're going to draw labs as well. It's important for us to know the type of elevation of cardiac enzymes that they have. Sometimes we're able to tell if someone's had an MI in the past because we'll see that it's been a few days and some of these cardiac markers will last sometimes up to 21 days. That's your troponin T, anywhere from 14 to 21 days. So these proteins are going to be released into the bloodstream because of our necrotic heart muscle tissue that now is going to be released into the bloodstream. So they're going to be those markers that we're going to look for, and they're important in diagnosing of MI. We need to know the onset, the peak, and the duration. And you can see in the graph that is showing you the difference in how many hours and how many days. Cardiac specific troponin has two subtypes. Well, we have troponin T and troponin I. These markers are very specific indicators of MI and have and very sensitive as well. And they're more specific when you compare it to your CKMB, because CKMB can be elevated with other things. Several levels of CKMB can increase in 4 to 6 hours after MI, and it can last up to 3 days. And when it comes to our peak for our troponins. It can, like I said, if we have troponin T, it's anywhere from the first elevation will occur in 3 to 5 hours, and it will last, like I said, 14 to 21 days. Then you have troponin I, which will initially be elevated 3 hours after, and the duration is 7 to 10 days. We do test myoglobin, but we really don't. It's not one of those tests that we're really going to focus on. Not when we have troponin, which is a much better test and it's more specific. The myoglobin is released usually in the circulation, usually within 2 hours after MI, and it peaks in 3 to 15 hours. Although it is one of the first serum cardiac markers to appear after MI, it lacks cardiac specificities. That's why we don't really rely 100% on that test. This is just a diagram showing you the elevation of these troponins and these cardiac enzymes. You have the CK and B, so as you can tell that when we draw these and the expected range, they have to be the troponins and T and I, they have to be less than a certain level. And as you can see, the different times of elevation and the days of duration. And with myocardial ischemia, these are some of the changes that you will see in your EKG. Normally, there may be an ST depression and a T wave inversion. You may also see a ST segment depression, and it's usually very small, only about 1 millimeter below the isocentric line, which is that flat line that you see. Changes reverse when adequate blood flow is restored to the myocardium. So you'll see changes after the patient has interventions. If there is that depression, ST segment, or the T-wave inversion, this is usually due to response to inadequate supply of oxygenated blood, which causes this electrical disturbance in the myocardial cells. With this one is showing you the injury, which is once you see ST elevation, and this usually is about greater than or equal to about 1 millimeter above the isocentric line. And if you could think of the previous one you just saw, the isocentric line was that flat line. So what happens is myocardial injury occurs, and this is a worsening stage of ischemia. It may be potentially reversible, but the MI, once it's there and the tissue has already died. The typical ECG change you see is that's ST elevation. ST segment elevation, like I said, is significant or greater or equal to about 1 millimeter above the isocentric line. If the treatment is prompt and effective, we can restore oxygen to the myocardium and avoid or limit the infarction. That's why we always say time is muscle, because we want to make sure that we do the proper treatment interventions as soon as we possibly can. And usually when they come in with the STS elevation like this, we will be able to confirm a true MI along with the EKG and elevation of the troponin levels. Now, as far as this one almost looks about the same, but you see the ST elevation there, and then all of a sudden you'll see this little T-wave inversion. Now that's another association with infarction. So in addition to the ST segment elevation, you may see a pathological Q wave may be seen in some ECGs in some patients with infarction. A pathological Q wave that develops during an MI is pretty wide. It's greater than about 0.03 seconds. And you'll hear that they refer this as a Q wave MI, and you'll see this in an ECG. Some of the diagnostic studies that we do, we will see
coronary angiography. Echo is very common. We can do a stress test too, but like I had mentioned before, a stress test is not something that would be done on someone with an ST elevation MI for sure. The coronary angiography is for a patient that has had unstable angina or non-ST elevation MI. They may go under this coronary angiography. There's some guidelines to this, and usually it's reasonable to do this on stable but high-risk patients. If appropriate, a PCI is performed at this time as well. Some patients may be treated conservatively with medical management, which would be like your non-ST elevation MIs. Coronary angiography is the only way to confirm the diagnosis of Prince metal angina. Exercise or pharmacological stress testing and echo are all used when a patient has an abnormal but non-diagnostic baseline EKG. A dobutamine or persentine or adenosine stress echo stimulates the effects of exercises, and these are for those people that cannot get on the treadmill, so they'll simulate exercise. So adenosine can do that, and persentine is usually the most common one out of the three. Dobutamine is one that they use as well. Now, more of collaborative care. It's extremely important to diagnose this pretty rapidly. Obtain a 12-lead EKG. Start continuous ECG monitoring. Position the patient upright position, unless of course contraindicated. Give some oxygen therapy to keep the oxygen saturation at least 93%. IV is important, and we need the IV to give emergency drug therapy. Give sublingual NTG and aspirin chewable. Have the patient chew it, not swallow it, if not given before arrival to the ED. What happens is that a lot of times, if patient calls an ambulance, some of these interventions will be started by the first responder, so EMT, like I said, just the first responders. They'll start initiating some of these interventions. They'll start, usually I've seen them give the nitro. They will give some aspirin as well, and morphine if the chest pain is not relieved with nitro. For this slide, we have your typical MONA. We give the morphine, remember, for pain that's not relieved with nitro, oxygen, NTG. We give up to 3 tabs. We give aspirin and Plavix as well. Ongoing monitoring for these patients, we're going to treat any dysrhythmias that they have. At times we will put them on antidysrhythmic medication. So if they do develop dysrhythmias, it's important to make sure these patients are getting their meds on time. Frequent vital sign monitoring, bed rest, limited activity for about 12 to 24 hours with gradual increase unless contraindicated. For patients with unstable angina or non-ST elevation MI with negative cardiac markers and ongoing angina, the treatment plan is a combination of aspirin, heparin, which is low molecular weight heparin usually, a glycoprotein, which can be integralin is what's recommended, or PCI of course, and is considered once the patient is stabilized and angina is controlled, or if angina returns or increases in severity. That's when they consider PCI. For patients with STEMI or non-STEMI that have positive cardiac markers, reperfusion therapy is initiated. That is the most important thing we want to do. Reperfusion therapy includes emergent PCI, and that's for your STEMIs. And non-STEMI, we do thrombolytic therapy. And if we give thrombolytic therapy, remember these are patients that we don't want to give IM injections. Many times we'll do 2 peripheral IVs and anticubitals, so we'll use those to draw blood because we don't want them to get frequent blood draws. The whole goal and treatment of MI is to salvage as much myocardial muscle as possible. So that is what's going. Remember, time is muscle. So the quicker we do interventions, the quicker we find out what's going on with our patient, the less damage there will be. Emergent PCI is the first line of treatment for patients with confirmed MI. definite ECG changes, and positive cardiac markers. The goal is to open that blocked artery within 90 minutes of arrival to the facility. That, of course, has a interventional cardiac catheterization lab. Not all of the hospitals have this. In the situation, the patient will undergo a cardiac catheterization. They're going to locate the blockage. They're going to access the severity, what percentage of the coronary artery is blocked, determine the presence of collateral circulation, and at this point also evaluate left ventricular function. During the procedure, this if they do stents, patients with severe left ventricular dysfunction may require the addition of an intra-aortic balloon pump therapy, and a small percentage of these patients will require emergent CABG. But as they sign a consent, like I said, they always have to make sure that they get consented for a full open heart as well. Some of the advantages of PCI is that it's definitely a great alternative to having your chest cracked open. It's performed with local anesthesia. The patient is ambulatory right after, once the patient's recovered. The length of hospital stay is about 1 to 3 days, compared to 4 to 6 with a CABG surgery. Sometimes it's more than that. It reduces hospital costs. Patients can return to work weeks sooner from a PCI compared to 6 to 8 weeks that they have to do cardiac rehab after a CABG. So there's advances in PCI. They've reduced a lot of the CABGs that we used to do in the past. Thrombolytic therapy, we'll do this if PCI is not available. Not all, like I said, not all hospitals have a cardiac catheterization lab, or if one is too far, we have a time frame that we want to do this in. Treatment of MI with thrombolytic therapy aims to stop the infarction because it dissolves those thrombus. Remember, it's a thrombus that forms and dislodges in your coronary artery, and it helps to reperfuse the myocardium. Thrombolytic therapy is a good option. Ideally, with the first hour after the onset of symptoms, prefer to give it at least within the first 6 hours. 30 minutes is the goal, 30 minutes from the time they arrive to us. Mortality is reduced by 25% if reperfusion occurs within 6 hours. That's why we like those 6 hours. All thrombolytics are given IV, and because thrombolytics lyse the clot, they also lyse other clots. So the patient selection is important. Someone that has just been post-op, they cannot have any thrombolytic therapy. There's contraindications to some of this. If someone came in with a head bleed, obviously you're not going to give them medication to bleed. So we have to make sure that the patient does meet criteria to get thrombolytic therapy. This is a little bit more about thrombolytic therapy. Each hospital has a protocol on how they give thrombolytic therapy. There's a lot of the practices that we do that are very common because a lot of hospitals will follow the national guidelines that have been recommended. So we're going to draw blood to obtain baseline labs. We're going to start 2 or 3 peripheral IVs, and all other invasive procedures are done before thrombolytic agent is given to reduce the possibility of bleeding. Depending on the drug selected, therapy is administered in one IV bolus or over a period of 30 to 90 minutes. We're going to evaluate heart rhythm, vital signs, pulse ox, heart rate. Make sure we evaluate lungs frequently. Regularly assess changes in neuro because we want to make sure that we do not give them a head bleed. When reperfusion occurs, you might start seeing some changes in your EKG. The most reliable marker is usually the return of ST segment to baseline. So this ST elevation now is going to be at baseline. Other markers include resolution of chest pain. Also, you will see, and it's very typical to see a rapid rise in cardiac markers within 3 hours of therapy, and then you're going to peak at 12, and then you're going to start having levels decrease. These levels usually increase because of the necrotic myocardial cells. They're releasing the proteins into the circulation after perfusion is restored within that area of necrosis. The presence of reperfusion dysrhythmias also occurs, usually accelerated idioventricular rhythm. This is a less reliable marker of reperfusion. These dysrhythmias usually are self-limiting and do not require aggressive treatment. So in other words, they'll kind of resolve on their own. A major concern of thrombolytic therapy is reocclusion of the artery. The site of the thrombus is unstable and another clot may form or spasm the artery. And because of this possibility, IV heparin therapy is initiated. Coronary revascularization with CABG is recommended for anyone who fails conservative medical management. If they have left main coronary arteries or three vessel disease, they're usually not a candidate for PCI, or if they failed PCI in the past and continue to have chest pain. And someone that may have diabetes, or we have to outweigh the benefits and the risk from PCI versus CABG. Coronary surgical revascularization. Uh, CABG surgery consists of the placement of conduits that transport blood between the aorta into other major arteries and the myocardial distal to the blocked coronary artery. This surgery will require sternotomies, which is a big cut right in the middle of your chest. This procedure involves one or more grafts using the most common one is the internal memory artery. We have a saphenous vein, radial artery, and minimally invasive direct coronary artery bypass is a technique that offers patients with limited disease an approach to surgical treatment that does not involve a sternotomy or CPB, which is coronary pulmonary bypass. A thoracoscope is used to dissect the IMA, which is your internal memory artery. The heart is slowed using esmolol or stopped with temporarily with adenosine, and then a mechanical stabilizer immobilizes the operative site. Here's a picture of what I'm talking about. They do also give the cold potassium-rich substance that they pour right into the heart to initiate the heart to completely stop beating. And then we have the heart-lung machine, which is the picture on your left. That's a heart-lung machine. So the heart completely stopped, and it allows the surgeon to operate on a non-beating heart. But in order to continue to perfuse all the vital organs, the patient is connected to what we call heart-lung machine. The internal memory, this is you also hear it as IMA. It's the most common, like I said before, and it's left attached to its origin, so it makes it much easier. But then, of course, it has to be dissected into the chest wall. Then it's anastomosed, meaning connected with sutures to the coronary artery distal blockage, and the long-term patency from EMA grafts is greater than 90% and after 10 years. Saphenous veins are used for bypass grafts. The surgeon removes the saphenous vein from one or both of the legs endoscopically. Sections are attached to the ascending aorta and then to a coronary artery distal to the blockage. The use of antiplatelet therapy and statins after surgery continues to improve vein graft patency. Patency rates of these grafts are 50 to 60% at 10 years. The radial artery is another artery that can be used for a replacement for one of the coronary arteries. Not commonly used though. We usually go with the ones that I've already talked about before. But it, like we said, if sometimes certain arteries can't be used, there's alternatives. This one is thick, muscular, and it is prone to spasms. Peri-op calcium channel blockers have to be given to control those spasms along with long-acting nitrates. The patency of this is not as long as it would be if we used the internal mammary gland, so that's why it's not used routinely. It's only patency rates up to 5 years and as high as 84%. There have been no reports of extremity complications, but if there are, this usually hand ischemia wound infection following the removal of this artery. Some collaborative coronary syndrome care. It would be coronary surgical revascularization, off-pump coronary artery bypass, There is a surgery that they'll do sternotomy, but they won't put the patient on cardiopulmonary bypass. In other words, they won't put the patient in the heart-lung machine. There is also robotic assisted surgery, and there is transmyocardial laser revascularization. Good to know, but usually not typical questions that we like to ask. So don't spend too much time with these collaborative care situations. Drug therapy is important because we do use it quite often. We've talked about a lot of these already, but I did want to let you know that there are many times that our patients are placed on IV nitro when they come in complaining of chest pain and the chest pain is not controlled or is continual. That's, let's say, someone with chest pain at times, and that chest pain is not controlled with our Mona traditional stuff. So we'll put them on IV nitroglycerin. We usually titrate this to control chest pain. We want to make sure we educate our patients that they can possibly get a headache with this. Watch blood pressure. We also give morphine sulfate, which is part of our Mona protocol. This one is a drug of choice for chest pain, and it's usually given if it's unrelieved by NTG. It does work as a vasodilator, and it decreases the cardiac workload by lowering the myocardial oxygen consumption. It also reduces contractility, and it can decrease your blood pressure and your heart rate. And in addition, morphine in some situations can help with anxiety and fear. It's very rare. I know we've always thought that morphine can depress respirations, but quite honestly, that's pretty rare. Monitor patients for signs of bradypnea or hypotension. Conditions to avoid in myocardial ischemia and infarction. Beta blockers is another one. This one decreases the myocardial oxygen demand by reducing the heart rate, the blood pressure, and contractility. The use of these drugs in some of these patients who are not at risk for complications of MI reduces the risk of reinfarction and the occurrence of heart failure. And if you recall a few slides back, we did say that a complication of MI can be heart failure. The continuation of beta adrenergic blockers indefinitely is recommended. It is part of our algorithms that we use in the hospital, or what we call our core measures. When people come in with MI, we want to make sure that we start them on a beta blocker. ACE inhibitors is another one. It should be started and continued indefinitely in patients recovering from STEMI with an EF of 40% or less. The use of ACE inhibitors can prevent ventricular remodeling and prevent or slow the progression of heart failure, which is one of those complications we've talked about. For patients who cannot tolerate ACE inhibitors or angiotensin II receptor blockers should be considered for, what I'm trying to say is anybody who gets ACE inhibitors, it's usually people that cannot tolerate angiotensin II receptor blockers. But we do use ACE inhibitors as well for other situations. Dysrhythmias are the most common complication after MI. These are usually self-limiting and are not treated aggressively unless they're the life-threatening dysrhythmias. Lipid panels we're going to do on all the patients. We want to make sure we see what their triglycerides levels are and their LDLs. After MI, a lot of these patients are predisposed to constipation because of bed rest, opiate administration. So stool softener is very important. We want to give these to facilitate bowel movements. We want to prevent them from straining, because if they strain, they will have a vasovagal stimulation. So we want to make sure that they don't strain, because we don't want them to go into bradycardia, because if they go slow enough, this can also provoke dysrhythmias. Nutritional therapy Initially, we will place these patients in PO, except sips of water until stable, because we don't know what type of procedures they're going to get. We advanced diet is tolerated to a low salt, low saturated fat, and low cholesterol diet. Total fat intake should be about 25 to 35% of total daily calories. Saturated fat intake should be about 7% of total daily calories. This is just a little diagram showing you the different types of fat in food. Now, nursing management. The very first thing we do want to make sure that we achieve or get from these patients is we want to make sure we start getting to know them. We want to start asking them about past medical history. We need to know what's their family history as well, because as we talked earlier when we discussed coronary artery disease, a lot of this stuff can come from a family, so it can be genetic. Heart failure, cardiomyopathy, hypertension, diabetes, anemia, lung disease, hyperlipidemia. These are all things that we need to know as far as history. We want to find out too if what kind of drugs they're on. Are they on any antiplatelets, anticoagulants, any type of nitrates? And don't forget that Viagra is considered a nitrate. And don't just think of Viagra as a medication that is used for erectile dysfunction. It is actually developed for pulmonary hypertension, and it was accidentally found to help men with erectile dysfunction. But it was the whole reason for the creation of that medication was for pulmonary hypertension. Angiotensin converting enzymes, beta blocker, adrenergic blockers, calcium channel blockers, all of these are drugs that we want to find out about. Any kind of history of present illness, describe to us any events that might have led up to what the patient currently came with. Any kind of self-treatments and responses is important to know. I talked about some of these in nursing assessment. We're going to get subjective data. And a lot of this is really a repeat of what I've talked about. For the exception of chest pain, we do want to find out how often they get chest pain. We want to find out if they get any indigestion, heartburn as well. We want to find out as far as stress, how they cope with stress. Do they have a stressful lifestyle? Do they have a stressful job? How do they deal with anxiety? Do they have anxiety? Any kind of feeling of impending doom? And remember, if a patient's asking you a question, always make sure that you want to do some therapeutic communication and always get them to talk to you more by tell me how that makes you feel or tell me how you feel. Okay, now objective data. As most of you know what objective data is by now, we want to see how they're breathing. We want to see if they're restless, anxious, and a lot of times if they do have anxiety, restlessness, they will be tachypnic, so they'll be breathing pretty fast. We're going to check for cool, clammy, pale skin. We're going to check for pulse deficits, any dysrhythmias. We want to find out if they have any S3s, S4s, any murmurs. Some of the nursing diagnoses that can be used are these here, and decreased cardiac output related to altered contractility and altered heart rate and rhythm. And we have a lot of evidence of that because they'll have a decreased blood pressure, elevation in heart rate, dysrhythmias, diminished pulses. Pain can be used because, as we know, they come in with chest pain, anxiety. Many of people are very anxious when they find out that they have a heart attack. They're going to believe that they're going to die, so they seem to get into a lot of anxiety, activity intolerance, and ineffective self-health management. Now our plan. For these patients, our overall goal is to make sure that they're comfortable, that we have preserved myocardium, because remember, time is muscle, so we want to make sure we preserve as much muscle as we can. We want to make sure that they get the proper interventions. So if they come in with ST elevation MI, we want to make sure we have them in the cath lab within 90 minutes. Then you have your non-STs, MIs. If we're going to do thrombolytic therapy, our goal is to at least start it within 30 minutes from the time from their arrival to ER. And if we're going to use TPA, that was usually within the 6 hours. We want to teach them to reduce all their risk factors and participate in a rehab type of plan. Sometimes some of these patients will have to end up going to what we call cardiac rehab. Some of the interventions, we've talked a lot about some of these. Nitro, morphine, oxygen. We know that they're going to be on a continual monitor. These patients will be on a monitor from the time they get in to the time they leave because they are cardiac patients, so they're constantly going to be on an ECG monitor. We want them to get rest and comfort. And as we know, bed rest is going to be ordered for them for the first few days. And then if they have an uncomplicated MI, we may want them to sit up in a chair for 8 to 12 hours after the event. And that's only if it's non-complicated. The use of commode or bedpan is based on patient's preference. And there's different phases of cardiac rehab. There's cardiac rehab phase 1, which usually occurs in the hospital. There's phase 2. That's once the patient has been discharged and they're at home and will continue from up to 12 weeks. Continues to 2 to 12 weeks. And then phase 3, which is long-term management of optimal cardiac health. Another goal is anxiety reduction. Anxiety is present in all of these patients to some degree, so our role is to identify the source and help them deal with their anxiety. We want to ask them what are they afraid of. We want to reassure them that they're going to be okay. Sometimes patients will ask you, am I going to die? So you have to just reassure them that they're going to be okay. But of course, if they're really, really ill, that might be something you would want to refer to the physician if they're going to have a bad prognosis. Emotional and behavioral reaction, we want to maximize their social support system. Consider open visitations. This is not going to be the patient where we're going to restrict any visitors because we need them to remain calm. Now with PCI, it's important for you to know this treatment and what it does and how you monitor these patients, because as we talked earlier, it is very common and we need to know how to care for them. So patients with ACS will undergo PCI or CABG surgery, but primarily PCI. Our responsibilities are going to be to make sure we're monitoring any kind of recurrent angina. If someone comes back to you and they just had a PCI and they're having angina, something is not right. You need to follow that up, because this is the reason that if they went back to get some more blood flow to the area, because they either ended up having stents or they ended up having the balloon that smashes the plaque in the coronary arteries, that should have relieved their chest pain. So if they're having chest pain, you need to follow that up. Frequently assess vital signs, heart rate and rhythm. Evaluate the catheter insertion site for signs of bleeding. So I look for any kind of hematomas. We need to do neuromuscular assessments of the involved extremity. By that we mean you want to be checking their pulses, checking capillary refill, checking for temperature, because since they went in through a big artery, you want to make sure that there is no disruption to circulation. And of course, bed rest per hospital policy. The picture here is just showing you how they can have this little balloon that's inflated and it dilates the artery by smashing the plaque on the side, kind of thins it out. Coronary revascularization by a CABG. That's usually someone who is going to be in ICU for about 24 to 36 hours. They're going to come out with a chest tube. These patients are going to be in full force hemodynamic monitoring, Many of them will come out with a PA catheter. They will have a radial line, and they will have epicardial pacemaker. And we are going to have to monitor their electrolytes very closely. We're going to restore temperature. Many of these patients come out very cold because we're in a cold operating room and they have their chest completely exposed, so they come out very cold. We have to make sure we put them for nice warm blankets when they come to you. We're going to monitor for atrial fibrillation, which is a very common dysrhythmia that some of these patients will go into. And if they are going to have it, it's usually common in the first 3 days after CABG. Post-op fib actually occurs in about 20 to 50% of patients, so very common. Beta blockers should be restarted as soon as possible unless it's contraindicated because we want to reduce the incidence of acute failure. Uh, this one here is complications that are going to be related to coronary pulmonary bypass. There is chances of bleeding, chances of having an imbalance with your fluid and electrolytes. And I talked about the hypothermia infection. There's always a chance of infection, especially after someone has had a large surgery like this. Assess patient for bleeding, monitor hemodynamics, fluid status. These patients do come out dry. That's what's important, that we monitor their CVPs, make sure that they're getting enough fluid because they did have a lot of large losses on average. Estimated blood loss for these patients about 1.5 liters. We want to restore temperature again and monitor for AFib, which we talked about before, that is very common. Surgical site care, we got to make sure that it's nice, clean, there's no reta present, there's no drainage present in the incision. Pain management, DVT control, pulmonary hygiene, and cognitive dysfunction. DVT is very common because of bed rest, so it's important that we ambulate or put compression stockings or use a compression device pretty early on, and hopefully the patient's on some kind of thrombolytic therapy to prevent them from getting deep vein thrombosis. Ambulatory and home care, we talked about a lot about cardiac rehab. Some of these patients will need cardiac rehab. Some of them do really well. They end up going home and they do okay. They're going to require a lot of teaching. These patients are going to may have a lot of new meds. There's going to be a lot of care activities that they're going to have to know how to do. They're going to have to know how to take care of themselves once they get home. So there's a lot of teaching. And if you happen to work in a unit where you work with different disciplines and one of them is an LVN, and once you begin your teaching, you can always have an LVN reinforced teaching, because reinforcement of teaching is important so the patient can remember. When we originally begin teaching our patients, we have to make sure too that we assess readiness to learn. A lot of people think that just because your patient's looking at you that they're going to be learning everything you're telling them. But if they don't have readiness to learn, then you're going to have a difficult time trying to teach them something. Many of them will wonder when they're able to have sexual activity. So just depends on their healthcare provider. And sometimes it's some of these will be written on their discharge orders, so we can go over it with the patient if it's written in the discharge orders. But if it's not addressed, then we got to make sure that the patient consults with his physician. In general, it's usually safe for them to resume sexual activity about 7 to 10 days after an uncomplicated MI. Having a calm, relaxing environment is important for them. And then got to make sure that we talked about Viagra, which is contraindicated with nitrates. And usually, as far as activity is concerned, usually about 7 to 10 days post MI. most patients can climb 2 flights of stairs. And when we prepare them, it's important to let them know how much pain and discomfort they're going to be in, and also let them know that if they live in the upstairs, it's better for them to reside in the downstairs until they get better. Evaluation, we've got to make sure that their vital signs remain stable, their pain was under control, we decreased anxiety, and all of our goals are realistic. We're going to make sure that our medications were effective and they did not give the patient any side effects. We want to measure or reduce all the risk factors, do rehab activities if necessary to manage them therapeutically. Sudden cardiac death. What this is an unexpected death. It can happen from a variety of cardiac issues. There's usually a disruption in cardiac function that produces a very low or complete loss of cardiac output, which, secondary to reducing cardiac output, you're going to have reduced cerebral blood flow. These affected people may or may not know that they have this. Sudden cardiac death is usually the first sign that they see, and for about 25% of those patients, they will die of heart disease. Coronary ventricular dysrhythmias causes a majority of cases of sudden cardiac death. Structural heart disease accounts for about 10% of all cases of sudden cardiac death. There's usually, going down to conduction disturbances, they'll have disturbances with prolonged QT, and if someone is in a continual prolonged QT, you'll throw them into torsades. Usually with these people, there's no warning signs. There's many people who never wake up, and usually it's that they die from sudden cardiac death. There have been situations where people will go to Big Bear, and because of the changes in the elevation of pressures, it creates more workload on the heart. If they already have a weak heart, at that point they won't wake up anymore because they'll go into sudden cardiac death due to the excess work placed on the myocardium, that they'll go into some kind of dysrhythmia. And if it does occur, it's usually within 1 hour of onset of symptoms. Sometimes some of these people will also die in the toilet because they did a Valsalva. And workup for these people who normally survive sudden cardiac death will require a lot of diagnostic workup to determine whether they have had an MI. Serial analysis of cardiac enzyme markers and ECGs are done with the patient, and are done early, and the patient is treated accordingly. Most people with sudden cardiac death will have CAD. Cardiac catheterization is indicated to determine how much is the damage or possibly location. PCI or CABG surgery may be indicated. There's 24-hour Holter monitoring, and some of these patients with sudden cardiac death will have lethal ventricular dysrhythmias that are associated with a high incidence of recurrence. It's useful when people are more likely to use their therapy effectively. Assessments of dysrhythmias are usually in patients that include 24-hour Holter. EPS, what that is just a study under fluoroscopy. So they put it in the pacing electrodes are placed, and they look at how the patient responds to different various antidysrhythmic drugs. The most common approach, however, though, is an AICD. If there is drug therapy, amiodarone is a great drug. That's an antidysrhythmic. However, there is side effects with amiodarone. It does prolong a QT and may also cause fibrotic lung tissue disease. So with caution, but it's a good drug for those who can use it. Teaching. A lot of teaching with this, especially the sudden cardiac death patient. Some of them will get an AICD. And when caring for these patients,
be alert to the patient's psychosocial adaptation with this sudden cardiac death. Many of these patients, they feel like they're ticking time bombs, and or some of them will have a big fear that this will happen to them again. Other issues can be these people sometimes will lose their license because they can cause accidents. If they have symptoms of sudden cardiac death and live to tell, we'll probably have to watch them. Hopefully, we'll prevent them from getting another one. But if they report this, it depends on the physician and how bad their sudden cardiac death episode was, that they may have to give up their license, their driver's license.